to begin. So I'd love to introduce Amali, an amazing physician with 26 years of experience in her specialty. Her main clinical interests lie in medical gynecology and general obstetrics, with expertise in normalizing birth. She has authored an acclaimed book called The Heart in the Womb, an exploration of the roots of human love and social cohesion, which Ina May Gaskin has called the childbirth without fear of the 21st century. She has contributed a chapter to the best-selling book, The Roar Behind the Silence, Why Kindness, Compassion, and Respect Matter in Maternity Care. Doctor, and you have to help me, I always have trouble. Say your last name.
Lokugamage.
Lokugamage. I always look at that and go, I know I'm going to say it wrong, so thank you. Dr. Lokugamage is an international invited speaker at many multidisciplinary birth conferences promoting respectful care, dignity, and autonomy in maternity services, as well as lecturing on the origins of compassionate behavior and social cohesion. Her international positions of leadership are being on the board of directors of the International MotherBaby Childbirth Initiative, of which we're so grateful for, a UN-recognized NGO, on the advisory board of Human Rights in Childbirth, and on the editorial board for the International Journal of Childbirth. She is an Institute of Leadership and Management, NHS champion for healthcare human rights, and Dr. I'm going to say it wrong again.
Lokugamage.
Lokugamage, I have to write it out phonetically for me next time, was a finalist in the 2014 NIH Leadership Academy Award under the Inclusivity category for her work in humanizing birth. She was given a University College of London Excellence in Medical Education Award in 2015. She has led Patient Engagement, Patient Experience Project, Footprints of Birth, which developed an educational tool to evoke empathy, compassion, and an awareness of human rights in healthcare and health professionals. She was also on the steering committee for a Whittington Health Compassion Conference in 2015, and she has several medical educational leadership roles at the University College London Medical School in undergraduate women's health, clinical and professional practice, and student support. Her international clinical work has been in cardiothoracic anesthesia in Colombia, Sri Lanka, 1991, and research into the treatment of postpartum hemorrhage at the University of KwaZulu-Natal, South Africa, and Asian tsunami charitable relief work in Sri Lanka and India in 2005 and 2016. Her research and publications look at the critical evaluations of evidence-based medicine, human rights in childbirth, normalizing birth, life course epidemiology, recurrent miscarriage, the use of misoprostol for labor and delivery, and international women's health. She has keen interest in integrative medicine and the psychobiological dimensions of diagnosis and treatment. In London, she leads the NIH Maternity Acupuncture Service, and she is trustee of the Birthlight Trust, where she's instigated a pregnancy yoga dance project. She also has expertise in the treatment of chronic illness, integrating both standard and complementary medicine modalities in a patient-centered approach. Amazing. I mean, reading your biography, I read it before earlier today and was so impressed, and reading it again for our webinar. We feel truly fortunate not only to have you on the board of the IMBCO, but to have you present today Step 5, provide the evidence-based practices that are proven to be beneficial. So with that, I turn it over and really welcome you and thank you for this webinar. And to everyone who's joined us, we really look forward to your participation.
Thank you, Deborah. That was a bit too long, actually. Perhaps I should have sent you a shorter CV. But anyway, let's start with the seminar on Step 5, providing evidence-based practices that are proven to be beneficial. And that's, you know, a wordle of the values that we have at the IMBCO. This particular IMBCI step dovetails with some other steps that have been discussed already For instance, step 1, treating every woman with dignity and respect. Step 2, possess and routinely apply midwifery knowledge and skills that optimize the normal physiology of birth and breastfeeding. Step 3, to inform the mother of the benefits of continuous support during labor and birth and affirm her right to receive such support from companions of her choice. And there's also a connection with steps that will be described in future webinars, such as step 6, to avoid potentially harmful practices and procedures. Step 8, to provide access to evidence-based skilled emergency treatment. And step 9, to provide a continuum of collaborative care with all other relevant healthcare providers and institutions and organizations. So I think I'll skip over my CV because Deborah's already sort of filled you out on that. But what is the definition of evidence-based medicine? Well, in the first paper about the subject in 1996, the definition was the conscientious and explicit and judicious use of current best evidence in making decisions about the care of individual patients. It means integrating individual clinical expertise with the best available external clinical evidence from systematic research. And I think this definition has evolved, and I too will evolve it during this presentation. So prior to evidence-based medicine, only a few obstetricians actually looked at the scientific literature when presented with a clinical problem, and personal experience and authoritarian views of experts had far-reaching influence over obstetric practice, so very authoritarian. So initially, evidence-based medicine was thought to be an equalizer. And what are the sort of good evidence sources? Well, there are online Cochrane reviews, there's the information from NICE, or the National Institute of Clinical Excellence. There are the Royal College of Obstetricians and Gynecologists Green Top Guidelines, that's RCOG Guidelines. There are the Canadian College Guidelines, the American College Practice Bulletins, and the Royal College of Midwives, for instance, has guidelines too. Some of these guidelines are very transparent, and you can see the quality of the evidence behind recommendations, and some just state the recommendation and it's the evidence behind the recommendation is a bit opaque. So for instance, this is an RCOG guideline, a little snapshot of one about premature pre-labor rupture of membrane, so in premature babies. And you can see it says grade A, that means the best sort of evidence saying that erythromycin, an antibiotic, should be given for 10 days following rupture of membranes. But then there are other sources, as I said, of evidence, such as from the Cochrane Review. And this particular bit of information ties in with the values of the IMBCI, saying midwife-led care delivers best outcomes with this Cochrane Review. And then a publication in the Lancet, the Mango trial, showed that caseload midwifery is safe, less costly, even for high-risk women. However, in the West, evidence-based medicine has grown, but in other areas of the world, in the developing world, practicing evidence-based medicine is a problem. And this is a snapshot of a publication from a non-maternity journal, but it does explain that South Asian countries, for instance, I'm originally from Sri Lanka, so I'm going to refer to that geography now in illustrating this point. It is known that political apathy, poverty, and health infrastructures and the resource limitation make an evidence-based approach difficult or virtually non-existent. There is the availability of telemedicine, but really evidence-based medicine tends to only happen in tertiary care. But for instance, I Googled the Sri Lankan Obstetrics and Gynecologists College website, and you can see that they have got a section so that anyone with a smartphone in that geography can look at the Sri Lankan guidelines, and there are also links to pre-existing guidelines such as the Royal College of Obstetricians guidelines. So this is a very good example of what can be done, and smartphone use is quite widespread, even in low-income countries. But then again, looking at, say, a publication of the situation in Sri Lanka, which is more middle income, but it too has its challenges, and the main barriers to practicing evidence-based medicine are insufficient resources, overwork, lack of exposure to the concept of evidence-based medicine, and a lack of time and lack of endorsement for the need to practice evidence-based medicine. But this begs the question, what is the evidence in obstetrics and gynecology? And so I'm going to talk to you a little bit about this. I can hear that someone hasn't muted their mic. It would be really good if they could just mute their mics. Thank you. So what is the evidence in obstetrics and gynecology? Well, I produced a paper with some co-authors that were medical students that I worked with. We looked at the Royal College of Obstetricians and Gynecologists guidelines. And essentially, they divide guidelines into something called a grade system, ABC, and TIC for just practices based not on evidence, but on clinical experience. But in 2007, they narrowed the bandwidth for this, making good quality observational studies category B, and category C became less good observational evidence. So I don't know whether you know this, but a proper guideline, and this is what we do for the RCOG, is that a committee is set up and there's input from clinicians and consumers, and the information is put together, and they use a guideline to develop the guideline, and it's peer reviewed in an open and formal manner. I mentioned the system, the grade system, ABC or ABCD, and that was introduced to try and to get some rigor into the classifications and try to make comparisons more transferable. However, the grade system has been criticized as being a bit simplistic. For instance, grade A is meant to be top quality evidence, and that usually is what we call a randomized controlled trial. But that type of sort of research study, if it's a complex thing that they're analyzing, can also have bias and prejudice in it. So it sometimes isn't the best quality. So when we looked at the RCOG guidelines, we looked at both obstetrics and gynecology. And we were quite surprised, actually, to see that grade A was only between 9 to 12%. And that's probably because it's difficult to do randomized controlled trials in pregnant women, especially in labor. And then, sorry, grade B, if you look at the Browner diagram, that has that B represents the best quality observational study. And you can see that amounts to about 12%. So if you add 9 and 12% together, you can see that the remaining recommendations are not based on very high quality evidence. If you drill down into just obstetric practice, you can see grade A is about 8%, and grade B, if you look at the right-hand diagram, which has a narrower bandwidth, it's a bit more precise, that grade B is 10%. And then if you look at this sort of, looking at evaluation, diagnosis, and mode of delivery, and this is the way a previous paper was set out. That's why we did the figures in the same way. You can see, say, for mode of delivery, that the evidence levels behind obstetric recommendations is actually quite, it's quite poor, really. And most of the recommendations are based on peer review and opinion. We published this year an analysis of the Canadian guidelines. They don't use the same grade system. They use level 1, 2, and 3. And then they further subdivide the evidence into a recommendation, which is more the committee's recommendation of the strength or value of a particular research finding. So slightly different. So it was more difficult to compare to the RCOG guidelines. But it is interesting that there's a discrepancy, that the recommendation, the things that are supposed to be recommended as good evidence, 43%, does not equate to level 1 and level 2, 2.1, shall we say. So that comes down to interpretation, clinical interpretation. The American College published a similar analysis that I alluded to, and they said that only 30% of the recommendations put forward by the college in its practice bulletins are based on good and consistent evidence, and that means grade A. So if you compare all of the 3 colleges that I've mentioned, you can see that although there's variation, it's certainly not the majority of recommendations that are based on really high levels of evidence. And so in the 2 papers that I was involved in, we certainly started evolving a discussion regarding shared decision making, and that really that these sort of helicopter view papers of the overall evidence were useful to clinicians and patients in the field of maternity care to make collaborative clinical decisions. But I think this needs to be evolved further, and certainly with my discussions with Hermine Hayes-Klein, founder of the Human Rights in Childbirth movement, there are certainly, this needs to be more fine-tuned, and I'll move towards that in further slides. Just out of interest, if you're looking at the whole of medicine, we found these other guidelines on infectious diseases and cardiovascular practice, and you can see that the levels of evidence are quite low in those clinical areas. The bottom grouping on cardiovascular risk was only sort of 3 different guidelines, whereas the papers that I've cited before and the ones that I've been involved with have examined over 1,000 guidelines. We're not the only people to notice that guidelines of specialist societies, not just in maternity, are surprisingly deficient. And here are some sort of snapshots of papers discussing this. In the New Scientist, looking at basic biomedical findings, which are not sort of patient related, but more lab related, they came to the conclusion that more than half of biomedical findings cannot be reproduced, and we urgently need a way to ensure that discoveries are properly checked. So their headline was, "Is medical science built on shaky foundations?" And then there are other papers looking at the philosophy of evidence-based medicine, such as this one. Is it actually, in light of that knowledge, evidence-based medicine, is it scientific teaching or belief-based preaching? And then some people in the areas or the geographies or the regions that have really grasped evidence-based medicine are now starting to find that actually the guidelines can be very restrictive. And you can see from this headline, this paper is alluding to that restriction. So it is interesting that an eminent British professor called Tricia Greenhoe and her colleagues, who are really reflecting on evidence-based medicine, produced this paper actually on the same date that our RCOG evidence paper was published. And they asked the question, is it a movement in crisis because of all of that I've discussed up till now? So in their paper, they said that the evidence-based quality mark has been misappropriated by vested interest groups, such as pharmaceutical companies, that the volume of clinical guidelines has become unmanageable, so people found it difficult cognitively to absorb the information, that the statistics of benefits may actually be marginal in the real life practice, the difference between the ivory tower and the shop floor, and that organizations can use guidelines in a very inflexible way and produce management that's kind of very technical and factory-like rather than patient-centered. And then, of course, guidelines don't work very well when people have complex illnesses. I'm going to just quickly show you a quick video in which Tricia Greenhoe explains this, and tell me if you can hear this, okay?
We're not hearing it well. A minute ago, before, when your husband reset it, we could.
Okay. Well, we'll skip this. And she's basically explaining very much the sort of factors that I've explained in terms of limitations. But let's look at other institutional practices. I think a lot of people interested in maternity care understand that the speciality is ridden by defensive practice, especially in the developed countries when where litigation and lawsuits against practitioners are quite common. And this whole process really distorts clinical practice. And then what is really not discussed very much is that people who work in areas where there are critical incidences, lots of emergencies, and that's not just obstetrics, but in, say, the ER, the emergency room, that the staff can have post-traumatic stress symptoms or post-traumatic stress disorder, anxiety and depression, which can negatively affect their behavior towards patients. So those are factors that are can underlie recommendations as well as the evidence-based guidelines. And you can see that from numerous large cohort studies that, that show that women who are low risk, who are healthy women, that if they give birth in an obstetric setting rather than a birth center or perhaps even home birth, actually have more interventions. Women have a higher chance of being admitted to intensive care, for instance. And there are a lot of debates about perinatal morbidity and mortality. And certainly there are retrospective studies which are not that good quality, but all that I've listed here are sort of prospective studies, the top three, and they, in the Dutch study, show no difference with perinatal morbidity or mortality between home and obstetric unit. But the British data shows perhaps a slight increase in morbidity illnesses in babies for first-time mothers. But I think with the general thrust for bringing birth into hospitals, it is starting to be noted that institutional care can become inhumane, that you can end up with factory line mentality with no dignity, respect, privacy and autonomy, and you can have numerous interventions such as being put on an IV drip or having oxytocin or having to give birth on your back without a choice, and episiotomy is given as routine without consent. And all of this is gaining wider recognition in the respectful maternity care lobby, and the World Health Organization has realized this in its statement on the prevention and elimination of disrespect and abuse during childbirth. And you cannot remove evidence-based care from human rights, actually. And the Frida Principles are a very simplified way of looking at human rights: fairness, respect, equality, and dignity and autonomy. But when going back to the fact that when you look at the cohort studies comparing low-risk women, you can see that when they enter an obstetric environment, sometimes their health is not respected. And this is well, I don't think I'll play this video, but this is talking about obstetric violence, not respecting the physiology and women's choices if they were healthy. But you can't just sort of damn hospitals, because again, there are several studies from many streams of analysis showing that that working in healthcare can be very difficult for those doctors and nurses, and certainly if they have difficult conditions, that breeds disrespect and abusive care. And this can be because of workforce shortages, scarcity, lack of promotional opportunities. And there are multiple points of suffering and complexity here. Catherine Hill quoting in USAID. And you can refer back to the slide on the difficulties of practicing evidence-based medicine in Sri Lanka, and it's very similar hurdles, as it were. And then, of course, in old-style medical schools, I think the previous training did not focus on behaviours as much as the more modern medical educations that are provided in universities now. So in the old style of training, I agree with Louise Aronson here, who says, we doctors do many things that are otherwise unacceptable. We are trained not only in how to do such things, but in how to do them almost without noticing, almost without caring, at least in the ways we might care in different circumstances. But I work at University College London, and in clinical and professional practice, and this is a snapshot of our website, and you can see that actually nowadays modern curriculum are trying to educate doctors in patient-centered care, and trying to put all the professional behaviours of kindness and compassion and the evidence base centred around the patient and their narrative. So there's hope for the future. I talked about how doctors make their decisions in recommendations, evidence being one, but evidence can also influence women's decisions, but so too can the influence of previous trauma and embodied decision making. There are some papers saying that about 18% of pregnant women may have experienced some sort of past sexual trauma, and women can also suffer secondary or vicarious trauma from listening to traumatic stories, and this can affect decisions, and women may not give any reason because of the stigma. The other decision-making the way in which women actually can make decisions which doctors don't quite understand, maybe from an embodied position. So to try and explain that a bit in a more technical way, Ivan Illich, who wrote several books looking at the practice of medicine and critiquing it, said that he coined a phrase called social iatrogenesis, that medicine tend to promote the body as a foreign object to the owner of the body. He says, somehow we've become cut off and detached from our own body, and our inner experience becomes symptoms rather than the things we feel. And I had a clip here from Sir Ken Robinson, who was knighted for his work in the educational system. But essentially, he was talking about the whole educational system, including that of medicine, promoting objectification of the body and disembodied knowledge. It may be the pregnant state that makes women talk about embodied decision making, because we're finding that there's fledgling research pointing to oxytocin increasing something called interoceptive awareness, which is embodied wisdom. It's the sort of state where you're aware of your inner homeostasis. So you'd be more aware of your fetus. A kind of, again, a technical way of perhaps saying is in the lower box there, interoceptive sensibility, the dispositional tendencies of internally focused self-reported beliefs and tendencies. But it's probably something that states of mindfulness point to in terms of self-awareness. So that can certainly make a woman aware of her bodily integrity. So no matter what the evidence that's given, she may decide something that is right for her body. And the word bodily integrity ties into the feminist view, really. And this is a quote from a suffragette who died for the feminist cause. She's saying, Emily Dawson said that the true militant suffragette is an epitome of the determination of women to possess their own souls. So it's quite interesting. In the UK, last year, there was a legal ruling. I don't think there's any comparison legally, but certainly in the UK, this law gives rights for women over bodily integrity of what is done to their body for either wanting interventions or not wanting interventions. And this legal ruling and the judge recognized that there was a theatre of medical paternalism. And the judge said there's no place for that model any longer. And this particular legal case looked at shared decision making, said it was important. But with this last slide, really, I'm going to discuss really the movement away from shared decision making, because, for instance, Hermine Hayes-Klein in Human Rights in Childbirth, I think she agrees with this point, that you can share the information with patients about evidence and whatever clinical expertise you have, but ultimately the patient gets to make the final decision, and those decisions take precedent over everything. It's not just the inclusion of patient values and beliefs in shared decision making within the construct of evidence-based medicine. So the term shared decision making is not quite correct when you apply human rights caveat to it. So really, we're coming to the end now, and this webinar was about the IMBCI Step 5, which was to provide evidence-based practices that are proven to be beneficial. I've discussed why evidence-based medicine can be beneficial, but I've also discussed the limitations. And in terms of decision making, we've discussed collaborative decision making, but we've also looked at both physician and woman factors. And ultimately, the woman is the decision maker over her bodily integrity. And we can provide, for instance, myself as an obstetrician, the best level of evidence-based advice. But ultimately, as I say, it's the woman's decision. Thank you very much.
Thank you so much. That was a fantastic presentation. This is Deborah again, and I'd like to invite all of you that are here with us to either post a comment or your questions that you might have in the chat box, or if you'd like, we are just, I think, 14 of us, and if we unmuted just kind of one or two at a time, then you could actually share a comment or question. So would anyone, any thoughts? You're a quiet group.
Well, I don't know if you can hear me.
Yes.
Okay.
Yes.
Well, I actually had this weekend. Well, it's I already posted it that I'm a home birth midwife in Belgium, and this weekend I experienced that you have like these guidelines that help you choose good care and help you choose good care together with the mother. But in Belgium, these guidelines are taken very strictly by the hospital. So I had a woman who had ruptured membranes without labor, and she didn't want to go to the hospital after 24 hours. So we chose to wait longer, but I did feel a lot of tension within myself, because I knew if she wouldn't get into labor after 48 hours or even longer, then at some point she might choose to go to the hospital, and then I would have the hospital being very mad, I say it, because I did not follow the guidelines on that, for instance, that are used in Belgium, the rules that they take. So that's so. This weekend I really experienced that it was hard. It gave a lot of tension for me, and it was exciting, but in a negative way. Just because if you really had to go to the hospital, then you would have had this situation that they would not be friendly at all, because you made a different decision together with the mom. So that's what I want to add.
Thank you. I think you're sharing your experience. Do you have a question, or are you sort of saying institutions are quite rigid and it's a real challenge to be patient-centered? Yes. When you move into that environment?
Mm-hmm, mm-hmm. Yeah, and it's also it was a good lesson for me to stay with a woman and what her choice was, and I was very happy that I have colleagues that supports that idea too. Because otherwise, it's hard to give patient-centered care here.
Yes, and it is a challenge. I don't know whether I have a specific magic wand answer for you, because that's precisely why I put these slides together, because I think institutions do not quite understand the human rights aspect of the woman as a decision maker, and I think it's something that we need to keep repeating, and we need to. I think that evidence-based medicine seemed a much fairer way of doing things, but your case is demonstrating that evidence-based medicine and the production of guidelines that perhaps don't have the strongest quality of evidence make care very rigid, and then unfortunately it can end up with conflict, but that's when you really have to have sort of good communication skills and keep calm and try not to see the other party as the other, and that's often the root of conflict, isn't it? Everyone's got the best, they think they've got the best interests of women at heart, but I think what
No, you fell away.
I think you've frozen for a second there. Is anyone else? Yeah, I think Amali, I'm not sure if your internet connection isn't working, but all of a sudden
she's gone.
Okay.
Oh,
there you are.
There you are. Yes. Okay. Okay. I don't know whether that helps you.
Oh, it's okay. I just wanted to share my experience because this was just very, very to the point of what I experienced this weekend. So thank you.
Does anyone else have a question?
And I'm seeing in the chat, Asha said, how do we start to locate decision-making in obstetric practice in women who have little social power and come into hospitals with fear and a background of little or no education? Great question. And Asha, I don't know if you're in a place where you want to unmute.
Well, of course, that is a conundrum, isn't it? And that's where the IMBCI come in with, birth friends, doulas, some sort of support. But it's very difficult. It is difficult in countries where women are very disempowered, and it's even difficult in countries such as the UK, where women have perhaps louder voices than, say, in India. What have you found in where you work, Asha?
Hi.
Asha?
Can you hear me?
Yes, I can hear you.
Great. Yeah, I mean, this is actually something that we've grappled with in India for quite some time, for almost a decade of work there. And, there's just so much heterogeneity in India. So it's very hard to make any one statement because there's just such a diversity of situations and settings. But, you find women are almost don't want the decision-making, because there's no sphere in their life in which they are decision makers.
Yes, yes.
Right? They're not decision makers at home. They're not decision makers in any respect. And they come into the primary health centers or the community health centers or the taluk hospitals. And, I think it would be obviously we're not talking about some kind of drastic sudden move where we say, this is it, and now you decide what you want. But, when you try to imagine even a vision of how this would unpack and how this would look, it's very hard to see it because they really, they're really in a kind of a state of surrender, if you know what I'm saying, a fearful surrender.
Yes. I think there's such a lot of work to do, isn't there, in raising, you know, women's autonomy over all aspects of life in so many parts of the world. It's a big task, and I you know, wouldn't want to appear ivory towered about human rights, but in respect to evidence-based medicine, which this webinar is about, certainly the IMBCI aspire to women being offered that, and in many countries of the world that isn't even on the plate, and there is sometimes a little bit of thinking of evidence-based medicine as the solution, but what I was trying to bring across is that it has its limitations too, and it can limit women as much as, you know, unevidence-based authoritarian care, which is, you know, what the Dutch midwife who said before you. And in India, of course, there's such huge obstacles for decision making. It may not. It's not realistic. But it's an aspiration, isn't it? It's an aspiration if we lived in a better world.
Yeah, it is. And I think, you know, maybe it's really an area to think about how to, you know, what kind of work can we do to start that process, you know, because I don't think on one hand we can wait till women are, you know, educated in greater numbers and empowered, and, you know, we have to start anyway. But I don't know what that looks like. But thank you.
It may look like, you know, more doulas, but then the doulas themselves may be disempowered. So it's a complex issue, and I'm sure hopefully local solutions are the best, really.
Thank you. And we have a question I just saw. I was looking back in from Helen. And again, Helen, if you'd like to unmute, do. But she says, what would you say are the essential evidence-based best practices during labor and birth?
Oh, that's a lot. I thought about listing them, but then I thought it would be a very boring talk. But I think continuity of care is obviously a very big high quality evidence-based recommendation, and that's why I put it in the first slide. But there are so many other variations. I think really I think continuity is the best, because birth is a psychobiological state, and we can offer lots of science and technology, but human kindness and the relationships somehow have some effect on the physiology of women. And I think that is one of the biggest things. And then, of course, place of birth isn't grade A evidence, all those prospective studies. It's more grade B. But certainly, I think, as in the NICE guidelines for place of birth, which are very, very sensible, it gives recommendations for choice of setting of birth, and I think it's a very, very valuable document. But then again, as a guideline, you shouldn't apply it, you know, for everyone. And for instance, the NICE guidelines that do suggest that low risk women should consider birth centres can upset women who really are afraid and want interventions. So you've got to be fair to both types of women, those that want interventions and those who don't. But I would say those are two big areas of good evidence. But evidence is actually good evidence. Grade A is quite hard to find, actually.
Thank you. And I'm seeing from Lina a good comment there, right? The uneducated women I know in India did make choices to not go to an institution. Once they entered a medical establishment, there was no choice or involvement in any care. But when information like you share, Amali, things may change.
Thank you, Lina. Essentially, I haven't got any, as I say, a magic wand solution. But I'm hoping in sharing this information and reflecting on evidence-based medicine that the best of the evidence can be shared to women if the clinicians have the ability and the working conditions where they can actually give that information. And, you know, we can aspire to a model of collaboration. But of course, in many parts of the world, that's wanting.
Yes. Well, I want to thank you so much. I know on behalf of all of us that are on and the many others that will watch this later, your presentation was a great contribution and obviously very needed all around the world. Even here in the US, I think so many women aren't really making decisions and understanding what the evidence states and what their rights and voice are in birth. So I think from the low resource to the high resource setting, this is an issue that's really needed. So thank you so much.
Thank you, Deborah. Thank you to everyone who has attended.
And we will be making this webinar available online at www.imbci.org, the International Mother-Baby Childbirth website. And I hope that many of you will go there not only to watch this one, but to look at the other steps as we put them up over time. So thank you all. And we hope to see you next month on the next step, which will be step 6.
Thank you. Goodbye.